Welcome to Conversations in HIV. I'm Greg Huhn from Chicago, where I am the interim chief for the Division of Infectious Diseases at Cook County Health and interim medical director for the Core Center. Joining me here today is Maile Karris and Antonio Urbina, and we're going to discuss one of my patients with HIV who reached out to me about 5 years ago during his move from Minnesota to Chicago. And let's start by hearing a little about his story.
Yes, I have been HIV positive for 15 years. I guess I did perceive myself at risk, um, even when I was HIV negative, just because of being a sexually active gay man and not always using proper protection. And when my doctor in New York told me, I wasn't surprised because I was now putting myself at even more of a higher risk because I was in a group of people that were also using drugs while they were during sex. I had a doctor when I went there that told me he wouldn't put me on any sort of HIV medication until I was sober. And that made me pretty angry considering that I thought, well, how dare you tell me that I can't take a drug that could help me and improve my health and save my life just because I happen to be struggling with an addiction.
So, as you can hear, he was diagnosed back in 2008, about 10 years before he got into my clinic. Um, he described his risk factors. He felt that he was at risk. He was perhaps not really engaged in the healthcare system or really within taking care of his own health. He was malnourished. He was underweight. He was using methamphetamine at the time, drinking alcohol excessively.
Yeah, I think a couple of things just coming out of that. Number one, I think his story really highlights the importance of everybody being trained and comfortable talking about sex and drugs with their patients in a non-judgmental way and providing and educating about HIV PrEP or pre-exposure prophylaxis.
Yeah. I agree. Those are, really, really important points. And just like specifically with kind of the use of chemsex,
Yeah.
specifically methamphetamine, if patients were to describe that behavior, for me, I would see them at being at very high risk for HIV acquisition.
Yeah.
And really kind of start that conversation, just like you mentioned about taking steps to prevent HIV.
Yeah.
So pre-exposure prophylaxis and taking that opportunity to kind of engage them in that conversation. So those are the things that kind of struck me about that case. And again, just to be denied access to a therapy, I think that's really unacceptable.
We really want to engage our patient, make them feel part of our warm and welcoming environment. They're there to depend on us to take care of them. So he did actually then enter into rehab. He was addressing his bipolar disorder. He was started on lithium. He was engaged in behavioral therapy. He was started actually on FTDF and raltegravir. So he was started on an integrase inhibitor regimen, and he certainly demonstrated good adherence. He moved along to where he would update to a single tablet regimen to L-vitegravir, cobicistat, FTAF, and then eventually to bictegravir. At the time, though, as he's moving through well-controlled HIV, he did gain weight. His weight was up to about 250 pounds. He developed hyperlipidemia. He really was resistant about starting a statin. He really kind of just wanted to stay on his antiretroviral therapy. And so again, once he came into my clinic, he was actually in pretty good shape. But now he's aging with HIV. He's 50 years old right now, and he's developing some of those comorbidities with obesity, hyperlipidemia, and probably some prediabetes as well. So let's move to the next voice.
My health has changed, quite a bit, I guess, over the 15 years. After I got out of rehab and I stopped using, I gained, it really affects your metabolism. And I gained a lot of weight. I didn't really, I guess, try anything as far as losing weight until recently because I just get tired of it. I don't know how much the medications might have affected that as well. But I needed something to give me a boost because there wasn't anything I was doing that was working. I wasn't really doing anything.
Yeah. I mean, I think he's absolutely right in that, regardless of HIV status, once you gain weight, it's just really hard to lose. There's just so many mechanisms that are, preventing kind of weight loss. Also, just coming off of like stimulant drug use that are anorexigenic and once you stop that, the weight kind of comes back on. So unless you're really mindful of like exercise and good nutrition, I can see kind of increase in weight being a big issue. I think it kind of reflects the population at large as well. Just we're now in a obesity epidemic, right? I mean, we rarely see HIV associated wasting or right? So I think it's more these kind of other, obesity related syndromes that we're seeing in our patients now living with HIV. So I think his story is not uncommon.
No, I agree. And I think clinics are starting to adapt to that. So we used to have a lipodystrophy clinic, and that person has been like, well, I'm not seeing so many people with lipodystrophy anymore. Maybe we can transition into a weight loss clinic, and we'd had nutritionists attached with both, and so now we're building a weight loss clinic, incorporating some of the medications that people use for weight loss. But yeah, in the context of an obesogenic society at large, people with HIV still do have more weight gain when compared to others. And unfortunately, there's populations even within HIV, women, older adults that are more at risk for this. And I do think, it does impact their quality of life.
What we do know that works but may not be sustainable is those lifestyle changes. And so for the general population in the diabetes prevention program, with diet, with exercise, and it's not, and the goal would be an 8% weight loss. And really a majority of patients that went on those programs did lose the weight. However, they started to gain that weight back after about 1 to 2 years. What we know now, again, for patients that particularly aging with HIV with weight gain, is that through many large cohorts, the DAD cohort, the VA cohort study, the VAX, large group out of University of Washington, that incremental weight gain in our patients is associated with incident diabetes as well as increased rates of cardiovascular disease. Right. And so we now have data from the Reprieve trial. This was actually a very large trial, taking a look at over 7,500 patients, not necessarily with risk factors for cardiovascular disease. The trial randomized patients to pitavastatin, a high-dose pitavastatin, which is a sort of newer statin, a little bit of different metabolism. It goes through glucuronidation and not the CYP450 system, so maybe more friendly with drug-drug interactions, to placebo. And really, this study was a success. 35% reduction in major cardiovascular events, 21% reduction in major cardiovascular events and death. And in fact, in the subsets of groups that were at moderate to high risk, they actually benefited more. So here now we have very vigorous data to say that should all of our patients now, regardless of their risk for cardiovascular disease, baseline risk factors, should they be on a statin? All right, so now he's concerned about his weight. He's concerned about fatigue. His major complaint to me was really just being fatigued. He does international flights. He's a flight attendant, has some erratic hours. But otherwise, when we focused in on his weight, his BMI was 31. His hemoglobin A1C was creeping up. It was 5.8. Again, he's on lithium. Sometimes lithium can contribute to weight gain. At this point, again, he remains undetectable. His CD4 is up to 620, and he's really within sort of a good frame of mind when it comes to any concerns about his bipolar disorder, very well controlled. Our patient was interested in the newer drugs for diabetes that we know now can drive toward a significant proportion of weight loss. These are the GLP-1, the glucagon-like peptide-1 receptor agonist particles. They activate this incretin system, hormonal system, to increase insulin secretion in response to glucose. They increase satiety, sort of a neurohormonal hormonal sort of axis, and then they delay gastric emptying. And so my patient opted to go on semaglutide, and as a once weekly injection. He's been 4 months on the semaglutide, which has decreased his weight by 26 pounds. It's brought his BMI down from 31 to 28. He has improvement now in his cholesterol and all the profiles for LDL as well as triglycerides.
So Greg, I did want to ask you, just with the GLP-1 use, do you know of any data of its use in people living with HIV?
So there's some data coming out of Netherlands that it's very well tolerated. There's really no drug-drug interactions. When we talk about the tolerability, it's going to be the GI effects, right? I mean, it's going to be, you actually, I mean, it's designed for that delayed gastric emptying to say, all right, where are you going to meet sort of that threshold of where you're going to get nauseous, or you don't want to eat, you may be vomiting, maybe be having some diarrhea. It sounds like patients sort of acclimate to that, but that's the major reason why they would discontinue. And if you discontinue, you're going to lose the effects. So there is limited data in HIV, and there's actually some trials. There is a trial, the SWIFT trial, that is examining the GLP-1 receptor agonist, semaglutide, in persons living with HIV, randomizing to the drug intervention for those with a BMI over 30, cardiovascular risk factors, diabetes, hypertension, dyslipidemia, to behavioral interventions. And again, we may have results there in 2025. So he was considering other alternatives for his antiretroviral therapy. I think we can move to the next segment of The Voice to see where he, again, sort of did his own homework.
I saw some advertising on TV, to be honest with you, about it. And I thought, oh, well, this might be easier than having to take a pill every day. So I just go, in once every couple months and, get the shot in each side. And then it's, I don't have to think about it. I haven't been on it that long, but, it seems to be the first couple of shots were pretty, I was pretty sore the next day because they're like into the muscle, but it seems that the more shots you go along, the easier your body just seems to adjust to it. It's probably not for everybody. I think it might be for people who don't take their medication every day or forget or can't. It might be a better route for them if they can just come in once every couple months, and then they don't have to worry about it, and they don't have to think about it.
I think his response to the long-acting injectables has been very similar to my patient's experience. The only real side effects that they've experienced have been these injection site reactions that typically are worse just those first couple of injections, and they tend to improve over time. I think what has been most impressionable to me is when patients have said, like, I feel now liberated, I feel free. It's so destigmatized, and there's still a lot of stigma associated with HIV. Like, they can take their antihypertensives or their statins, but having to take that HIV medication is still very stigmatizing. So what's most impressed me is how liberating starting on these long-acting injectables have been.
I agree. I think my experience and our experience, I had seen in the studies from the clinical trials about how participants preferred the injections, even though they all recognize, yes, it's painful and we do have injection site reactions. But I think it was really interesting to hear from them, and then now my patients, how much freedom it does give them, because they don't have to think about their HIV anymore. So it's been particularly transformational. It's been very helpful in a couple of our folks that are at risk for intimate partner violence when they're in serodiscordant couples, and if the partner accidentally finds out, that could risk their personal safety. It's been really great, particularly in that context.
The concern about patients who are coming to clinic and really being reminded and stigmatized with again the persistence and the perseveration of their living with HIV. I was concerned actually with the need to come back every 2 months, even stepping into that clinic, every 2 months. Could that be triggering? And that has not been the case at all. They come to the clinic, they have an appointment for an injection, they're in and they're out. And the nurses are all ready.
Right.
They've got, they've just got it ready to go. Um, and for them, I mean, it surprised me that this is actually more of a convenience to just really pop into the clinic, get the injection, and leave. For our medical center right now, it's about 95% of all our patients that are going on these long-acting injectables are virologically suppressed, as is the indication. We do, however, have about 5% that have never really been virologically suppressed or controlled on oral antiretrovirals, cannot take oral antiretrovirals, or who have extensive resistance to where they actually need this injectable as part of a more comprehensive, multi-dimensional antiretroviral regimen. New data again. First, the Vanguard, Monica Gandhi out of UCSF and San Francisco General Hospital, Ward 86. They had 57 patients. Among their whole cohort, this is a vulnerable population. 66% had unstable housing, 33% had active substance abuse, primarily non-white population. They have a bi-weekly meetings where they have outreach for patients, make sure that they have all the tools for adherence and getting into the clinic and getting into any of the lab draws that they need. These patients, 57 patients not virologically controlled, started on cabotegravir rilpivirine. 55 actually got virologically suppressed. The 2 that did not get virologically suppressed actually did have a 1 log drop. They were very careful about monitoring for resistance. 2 of them did develop resistance. They actually did every month injections for these patients, whereas most of my patients are going direct to inject from their oral antiretroviral therapy to every 2-month injections. And there's been again there's been some early investigation. Can there be home injections? Can you inject into the thigh, the vastus lateralis? That really hasn't really worked out. As far as PK, yes, the PK is there for IC90 levels. Do patients want that? Are patients satisfied with that? Absolutely no. I mean, they're opposed to that. It's too painful.
Yeah.
So right now, as far as an IM injection, it's as we sort of learn through the early steps of implementation, this has been attractive to our patients. I think with newer agents, newer long-acting agents, every 6-month agents, various modes of delivery beyond just intramuscular injections, I really think it's quite a phenomenal time for drug discovery and for our patients to control HIV, and as we march toward ending the HIV epidemic in 2030.
Agreed.
Absolutely.
I think it's really important that we all learn from the patient voice. This is the reason why we became doctors, right? To take care of patients, to nurture patients, to understand patients, and to really just develop that rapport. And it really kind of enriches us as we know that certainly there's so much benefit that we are able to offer to our patients. So I'm really happy to be here, that we're able to sort of forward this really encouraging message to providers and even to patients who are able to access this type of education.